So, this is the second video of Lap Hellers cardiomyotomy series. The diagnosis is type 2 achalasia cardia. You can see the barium swallow, it is a delayed film shows delayed emptying, and endoscopy shows dilated esophagus. All cases endoscopy is must to rule out pseudoachalasia. The manometry shows type 2 achalasia cardia. So, this is supraumbilical camera port, right hand working, liver retraction, left hand working and stomach retraction. So, all 5 ports is the standard for any upper GI surgery or transhiatal surgery, and head and up is done. This is supraumbilical port camera view on OG junction. This is the right hand working port from left subcostal. So, this is the right subcostal close to camera. This is the left hand working port. This is the for retraction. In this case already liver is retracted. I put the port little later. So, by retracting the stomach, gastrohepatic momentum is being exposed, and I am going to divide the window, Kushner's window, and so this is a lateral approach. Some surgeons are doing anterior approach. I am doing a lateral approach. So, this is a caudate lobe and right crest. Once you open the gastrohepatic momentum, you can see the caudate lobe and right lobe. You have to take out the fat covering, the peritoneum with the fat covering of the OG junction and the right crest. So, I take out the fat. I am going on lateral, that inferior phrenic vessel is seen nicely. Again the fat attachment to the right crest I am dividing now. You can appreciate now very thin layer is there, so that the fat will come to esophagus side. So, I am trying to enter into the hiatus. Immediately the first structure will be the posterior vagus trunk. If you are not careful, you will injure the postvagal trunk when you are entering into the hiatus. So, that is the postvagus trunk. So, that is the postvagus now. So, I am entering into the hiatus. Sometimes I do the retroesophageal dissection first, then I go to the hiatal site, because I am going to all my cases I am going to do posterior Toupet 180 degree Toupet fundoplication. Suppose you are doing anterior fundoplication, this dissection is not required. Now, you can appreciate the inferior phrenic vessel. So, now I am going to the hiatus. Esophagus is being exposed, and carefully I am pressing down the esophagus. I feel the anterior vagus trunk in my left hand instrument. So, I identify the trunk, left pillar of right crest and the phrenoesophageal. The white color is the phrenoesophageal. Once you divide the phrenoesophageal circumferentially, then only we can tell that esophageal mobilization is completed. So, that is the right vagus now, and sorry, that is the postvagus, anterior vagus, this is the postvagus, and inferior phrenic vessel is seen very nicely. So, retroesophageal dissection is completely done. You can see the wide opening. Some more dissection is required, that is the postvagus. Along with the esophagus, I lifted the postvagus. You can see the crest. I am using harmonic HD. You can see the very sharp dip. So, that I am dividing the, now you can see the phrenoesophageal very well. I am dividing the phrenoesophageal from the crest. Below is the inferior phrenic vessel. So, now inferior phrenic vessel attachment is being divided. So, that is the phrenoesophageal. So, now its esophagus is mobilized completely all around. So, I am making another port, subsified port, so that retraction of liver is better. So, I can do the transhiatal, transmediastinal dissection, and most of the, that is anterovagus and postvagus, most of the time esophagus will be dilated and then little bit tortuous, and commonly on the right side. So, that is why we dissect the right side first to straighten the esophagus, that will relieve the symptom. So, always myotomy to be done by straighten the esophagus first, and then mobilize the esophagus on the anterior and right side and left side, and posterior very minimal dissection is enough. If it is a curved is there sigmoid, then you can do posterior dissection. So, already I have done right side, anterior, and then this is the left side I am doing it. So, left pillar of right crest is being separated, retracted, Now you can see I push down the esophagus. I cannot hold the esophagus at any time. You can see I open the instrument, I press down the esophagus. So that can be done. Always careful about the vagus now, and all the vagus to be preserved. Otherwise, it may lead to some gastroparesis postoperatively, particularly anterior vagus, that is a motor function. So here I am trying to straighten the esophagus, dissecting right side and posterior, and you can see my liver retractor is entering into the hiatus, retracting the right lobe of right crest, so that mediastinum is exposed nicely. So that is the advantage of this type of retractor compared with the Nathanson retractor. You cannot go to the mediastinum with the Nathanson retractor. So I am dividing the greater curvature side and fundus side. So I am mobilizing the fundus. I am entering the lesser sac. So only one or two vessel to be divided. It is because I am doing only the posterior Toupet. I am not doing Nissen. No one is doing Nissen on Hellers. Only anterior doors fundoplication, that is 180° anterior, or posterior Toupet 180° posterior. So that is the attachment of the post fundus on the pancreas. I observe most of the patient with the Hellers, the fundus will be very small fundus, and sometimes after mobilization I cannot complete posterior Toupet because of the very short fundus, and rarely I have done anterior 180 because fundus is very short. Most of the time I could able to complete with the posterior 180. So once you see the entire left side crest, let us say left pillar of right crest, then your dissection is completed. Your mobilization of fundus is completed. If you find difficult on that side, you can do it from this side. Some more attachment is there. So if it is necessary, we will divide that attachment. So now you can see this is the small vessel is there. It must be maybe posterior branch, post branch of gastric from the splenic artery. So now this is the time for mobilizing the anterior vagus along with the OG junction pad of fat. So this time you can see I open one peritoneum layer covering the stomach. You can see the bad muscle. So that is very important, and so that myotomy will be easier. And always dissect and then cut. It should not injure the anterior vagus, and you should not hold the anterior vagus with your left hand instrument. You can see I am holding the fat, not the vagus. So that is a lesser curvature. Here the vagus branch to the lesser curvature will be there, that can be divided, and you should not enter the esophagus. By doing this, should not go deep and then enter the esophagus. So now I am on the esophagus. You can see that again the layer covering the esophagus is removed. You can see the longitudinal muscle of esophagus, so that your myotomy will be easier. Without this type of vagal mobilization, don't do myotomy, that will be incomplete. You should not go deep also. That's why I'm saying both side, right side and left side. And the aim is to take out these peritoneal covering area, so that the muscle will get bared. So myotomy will be easier. So up to what level you want to have myotomy, you can divide this layer. So that is the vagus nerve. So all the time I'm holding the facial covering layer covering the vagus on the left side. Now I have started the myotomy, and previous video I use cardiomyotomy scissor, modified sugar baker cardiomyotomy scissor designed by Palnivellu sir, and this surgery I am using only the Maryland monopolar Maryland dissector. Initially, the first step is to apply minimal cautery and then separation of longitudinal muscle, because a lot of blood supply is there only on longitudinal, not on circular muscle. So, I am separating the longitudinal muscle with applying minimal cautery. You can see up to what level you want. I am separating the muscle. I am not concentrating on the circular muscle dissection or division. I am going only second. So, I want to go to that level. So, I am coming down now, and again 2 centimeter from OG junction I started separating the circular muscle from the mucosa, and then I am dividing the muscle. This is called division of circular muscles. So, you can see when I divide, I am not applying any cautery, just I am tearing the muscle, see like this, because very rare blood supply to the circular muscle is once in 3-4 centimeter small vessel will come. So, otherwise it is just tearing like this is enough, only the longitudinal muscle has a blood supply. So, here it is only just tearing is enough, very small vessel, so bleeding will not be happen. During this time Ryle tube will be pulled out, and I keep the Ryle tube in the mid of esophagus, and then after myotomy I can introduce the Ryle tube, then I place the air, and then I do air leak test. So, I am going up. So, I divide the longitudinal muscle for some distance, almost around 10 centimeters, 9 centimeter from OG junction, and I am going that level. So, that is enough, is no need to go up. If it is a type 1 or type 3, type 1 means I go a little bit more, and then type 3 also I have done in some cases. If possible, I will show that video also. And type 3 achalasia cardia is required more than 15 or 20 centimeter, more than 20 centimeter length of myotomy. So, in that case I retract the crest, both the pillar, right and left pillar. I can go into the mediastinum, I will do the myotomy. So, this is now I am marking the gastric myotomy, gastric side, and usually 2 centimeter or maximum 2.5 centimeter. I marked first, and then I started division of the fibers. And here it will be oblique fibers in OG junction and gastric side. OG junction is not much oblique, but gastric side will be so much oblique, and all the mucosal injury, most of the series is happen in gastric side rather than the esophageal side, because the gastric mucosa is very thin and you have to be very careful. So, I am in OG junction now. So, that is the OG junction, I am separating. You can see by pulling out the longitudinal muscle, these fibers are getting separated. And it is not since it is obstructed at OG junction, it is not, don't expect very thick muscle fiber and then required harmonic or any other energy device to divide, but it is functionally it is failed to retract, failed to relax. So, that is why patient is having a dysphagia. So, otherwise muscle is not taken, only the esophageal wall circular muscle will be thickened, but because of the repeated hyperperistalsis of the esophagus, the circular muscle will get thickened, not the muscle on the, not the sphincter muscle. So, now again I am marking the gastric side, and then even 1.5 centimeter on the gastric side is also enough in case of very early presentation, but normally 2 centimeter is required. In recurrent hernia, I go for 3 centimeter of gastric side myotomy is required. Now, you can see that is length is adequate, but only thing the muscle to be separated. These are all very much oblique muscle. You have to be carefully separated the oblique muscle. So, both hand Maryland is ideal, so that equal traction can be given, and very little amount of cautery I used when I separating the longitudinal muscle, otherwise I am not using any cautery. So, energy device is not much used, and carefully under vision we are separating the fibers, and you can see after separation I hold the muscle on both sides and then I open it up. It's almost anterior 180 degree of mucosa is getting exposed, and then I am doing a myotomy, I am doing a fundoplication, Toupet. So, this again it will retract the muscle away. So, again the anterior side, anterior wall of side of mucosa will get open. Now, you can see one muscle is there coming obliquely. So, I am going to take this muscle. So, that is this muscle fiber. I am going to take this muscle, divide the muscle fiber. So, slowly you have to do, only you have to do it in patiently, but do not fear of mucosal injury, that is very rare. Unless you do some dissecting kind of movement with the Maryland, they try to separate the muscle by dissection technique, then they will injure the mucosa. Otherwise, you can see it is very easy. It is not. It took around 10 minutes or maximum 15 minutes time to myotomy. Even though I am doing it very slowly, it will take only that much time, and it's almost unedited video. So, and any bleeding is there, I don't apply it. Now I am inserting the Ryle's tube. You can say I ask the anesthetist to introduce very slowly. See, most of the time they introduce very much fast, and then ask them to slow under vision, they have to push. Now I am guiding with my left hand forceps. So, you can see no thick mucosa. Esophageal mucosa is always thick, only the gastric side will be thinner, and if it is any bleeding in my myotomy area, I do not apply cautery immediate. Now, you can see the length is almost around 11 to 12 centimeter length. So, that is enough. I am going for a Toupet fundoplication now. So, here I am taking this fundus between the esophagus and the anterovagus. So, for that I mobilize this vagus a little bit on the right side, so that the fundus will come here. The Toupet I can do very well, comfortably Toupet. Do not keep it on over the vagus. So, this is the extra fat or great momentum side is there. Now, this is the time for air leak test. Since the Ryle's tube is inside the stomach, I ask the sister to push the air into the stomach. You can see air is coming inside the stomach fundus, there is no leak. So, I am not doing a endoscopy regularly in cardiomyotomy. Only thing in a redo fundoplication or redo Hellers, I am doing a endoscopy because of the anatomy is varied and any injury is we have to see. But regular case, even if you do endoscopy, you are doing only the air. No? So, here it is very easy with the Ryle's tube, and arranging endoscopy during laparoscopy, it's a little bit time taken and cumbersome method. So, that this is the easier way. So, this is a very relaxed fundus, no tension. So, little bit tension is there, I am just seeing that area. So, I am releasing it again from the pancreas. You have to be careful about the splenic artery when you are doing this step, because it will run a superior border of the pancreas. So, now you can see now how much it is relaxed. For a fundoplication, we used to keep a umbilical, we used to keep a cotton tape on the OG junction, we retract the esophagus, but here we do not do. Only some tortuous esophagus, then sometimes I use a cotton tape. So, now it is good, and I am going to take a stitch, usually 3 stitch on right side, divided end of the esophageal muscle to the posterior wall of fundus. That is 3 stitch, and then other side 3 stitch. So, totally 6 stitch, the Toupet, posterior Toupet fundoplication is done. Reflex control is good, better with the posterior Toupet fundoplication. Again, posterior wall of fundus to the divided edge of esophageal muscle on the right side. This is the polyester suture, ethibond suture, 2-0, small needle, and very much pliable, easy to use, memory is very less, so very easy to use. Only thing sometimes not get loosened. So I have to do very carefully. Sometimes I make a 3 throws instead of 2 throws, and most of the time 2 throws will be good. So, square knot is made, always 4 knot to be done. So, again this is the anterior wall of fundus to the divided edge of the muscle on the left side. I am not taking the mucosa. Now, you can appreciate 180 anterior 180 degree, now anterior mucosa is completely exposed. So, this is one of the surgery, all the gastro surgeon and general surgeon can do, laparoscopic surgeon can do this technique. Here, both the thing is corrected, the dysphagia is corrected by myotomy, and then the reflux is common after myotomy, that is also corrected with the fundoplication. So, everyone's fear is injury, mucosal injury of the esophagus or stomach. So, that is why I am explaining in step by step how to do myotomy without any injury. So, I am going to publish another 7-8 videos. So, totally 10 fundoplication video definitely will be helpful for you to learn this technique, and anyone can do this technique, so that achalasia cardia treated in laparoscopically. So, that is gold for me, it is a gold standard for a Hellers cardiomyotomy with the Toupet fundoplication is gold standard for achalasia cardia. So, this completes the procedure. Thank you so much.